When the patient initially presented, his tumor was on the right side, which certainly confers a worse prognosis. It was somewhat obstructing, not completely obstructing. That's why he's a T3 and not a T4. So there was still a passageway. His risks of recurrence without chemotherapy at the time would have been a little bit more than 50%. And for a patient, at least at his initial presentation, younger, healthier overall, FOLFOX would make a lot of sense, which essentially is what he received. The question today is mostly 3 versus 6 months. At the time he was treated, the standard was 6 months. Obviously, the patient was not able to complete the full 6 months. He completed 9 out of the 12 cycles, planned cycles, which is kind of expected with oxaliplatin, mostly because of the cumulative neuropathy. But I do believe that the patient was adequately treated at the time with the surgery followed by adjuvant therapy to cut down on the risk of recurrence. Unfortunately, the patient ultimately recurred anyways, and that could partially be related to the location of his tumor. Surveillance itself is a subject of great debate. A number of studies suggest one way or the other. Some studies suggest that perhaps just routine follow-up with no scanning with labs would be more than sufficient. We tend to argue that you probably need a scan, at least in the first 2 to 3 years, because the most common time for recurrence is in those first 2 to 3 years. Obviously, in this patient, it took a little longer than that, which we see in the rare patient or in the unusual situation. But most of the recurrences happen in the first 2 to 3 years. The other debate is about the frequency. We tend to be a little bit more conservative and do it every 6 months for the first 2 years and then one more at the 3rd year. However, if you look at the guidelines, they are a little bit loose. They suggest 6 to 12 months in the first 2 years, and then maybe another 1 or 2 on a yearly basis after that. So there is no specific guideline that's supported by high-level evidence. It's mostly a good level evidence. It's also, what we feel comfortable with. The reason why we like to do those scans, especially earlier on, if a lot of these patients may present with isolated liver lesions or isolated lung lesions, and we can certainly consider resecting them and provide the patient another shot at remission and maybe for some cure. Unfortunately, in this patient, it's a little different story, but that's overall why we try to be a little bit more conservatively aggressive with the scans.